So my topic was innovation in managing severe calcium, and as we all know, there's been a decent amount of innovation in the past. I'm just going to do a quick review. As everyone knows in the room, in the audience, prevalence of calcium is increasing. We're seeing more patients with it, and now as our CHIP population goes ever increases, we're seeing a lot more calcification in our coronary vessels. And we know that there are a lot of complications due to coronary calcification. We know that the vessel is prone to dissection when you do balloon angioplasty. We know lesions are difficult to completely dilate. We know stents don't adequately expand, especially when you do intravascular imaging, as you'll see on the right of your image. And you can prevent stent delivery if you're unable to truly debulk the calcium that's there. And you really have uneven drug distribution that's really associated with restenosis, which has also been shown as well. And we know that the presence of coronary calcium really portends to worse outcomes. This is from the Horizons and the Acuity data set. As you can see here, a total of 3,000 STEMI and non-STEMI patients. You can see here that severe calcium definitely had the worst outcomes to overall MACE and going through the entire gamut. And we know that angiography underestimates calcium, and I think as we've seen in the last couple of years, a very significant uptake in intracoronary imaging, and I cannot stress this enough. You know, what we see on angiography definitely does not really tell the whole story, and we really need to do more and more imaging to really tell the whole story. But once in a while, you do see coronary imaging, and you'll not have to really do much to tell that you have a lot of calcium. When you see railroad tracks going down your vessels, you know that you have a lot of calcium, as you can see in this RCA. You can see the vessel without contrast, and you can see in that LAD, when you see the vessel without contrast, you know there's a lot of calcium. And we'll talk about this. So we know that rotablator, tried and true tested, has been around for over 25 years. Really a catheter-based interventional technique, high-speed burr. It's diamond-coated on the front tip, ranging in size from 1.25 to 2.5 millimeters. And it's been used for a very long time for debulking and improving PCI success. Orbital atherectomy is a relative newcomer on the block. Its orbital mechanism uses differential sanding. It's something that's been available for the peripheral, and for those who do peripheral vascular debulking interventions for a while now. And I'd say in the last 5 to 6 years, it's actually increased in uptake in the coronary vasculature. And you can see here that it's extremely effective in doing what it used to do in the peripherals in the coronary world as well. Both rotablator and CSI, or Diamondback, or orbital atherectomy. You can see here that the difference is really rotablator is front cutting, CSI Diamondback is differential circumferential cutting. You can see here that the range of sizes for rotablator in terms of its micron sizes are anywhere, in terms of its burr sizes, are anywhere between 1.25, like I said, to 2.5, whereas the Diamondback comes in one single catheter with 2 different speeds. It's a 1.25 catheter size, and depending on the speed, if you go up to 120,000 RPM, you can get an arc, depending on the vessel, as large as 1.9 millimeters. The size and the exposed diamonds and the grit size are, of course, different between the two. However, and the mechanism is very different. However, the overall outcome is what we're trying to be the same. So we actually at Northwell had to have an ongoing registry, which is now almost 2,000 patients large, but this is our report from the last 1,000 patients that was submitted and published earlier this year. You can see here that we had a total of 474 matched patients in the rotational versus the orbital arm for lesion characteristics. And you can see here that procedural and safety outcomes were very good across the board, fluoroscopy time being a little less with orbital atherectomy. And if you look at the primary and secondary outcomes, with the exception of an increase in a higher number of rotational atherectomy mortalities, which in the end, when you did a non-inferiority analysis, really showed to be no different. You can see across the board that really myocardial infarction was the biggest one. And you can see the difference between orbital and rotational atherectomy. But the goal of that paper was not really to show one device was better than the other. Really, the goal of the paper is to show this. This is what the temporal trends have been in our use of orbital rotational atherectomy. You can see here when orbital atherectomy started its play in 2014, you can see the uptake in the number of cases per year of orbital and rotational atherectomy that are occurring at our institution. And this is probably, we are not in any way unique to this. This is happening across the board because we're able to do things that we weren't able to do, ranging from taking care of more complex lesions, using better bifurcation techniques, hemodynamic support, you name it. So lesion characteristics in terms of looking at the two vessels, we put together a few slides to say, hey, what are the differences? One would use one versus the other, albeit you could say you could use both in almost all cases. I'd say larger the vessel, orbital may be more effective because you can use one burr and change the speeds rather than changing burrs. Smaller the vessel, rotational, in my opinion, is definitely safer, engages smaller vessels better. And with tortuosity, I'd say the same. Rotational atherectomy definitely, because of its floppier wire, definitely tracks tortuosity way better than orbital atherectomy. However, less tortuous vessels, they're very much the same. More tight concentric calcium, as we all know, orbital atherectomy does not front cut, whereas rotational does, so therefore you have that front cutting engagement of that very tight concentric calcified lesion. And osteal lesions, we'd say that right now rotational still remains the ideal choice for that osteal RCA or osteal left main, albeit there are many people who use orbital atherectomy in that scenario. You can see here in a certain case, here's a very osteal RCA calcified lesion and a mid-calcified lesion. This is a case that a patient with a very low EF, so we use hemodynamic support. And you can see here both for rotational atherectomy of the osteal lesion going all the way through, we were able to successfully treat this lesion. Another thing that we have to always keep into account, and I'm sure fewer and fewer of us are using pacemakers in doing these atherectomy cases, and you'll see here that we published this back in 2016 at ACC, and this suggests that orbital atherectomy actually requires less pacemaker activations than rotational atherectomy, and it's something that people have been seeing all throughout. Atherectomy also, the orbital atherectomy has bidirectional atherectomy, whereas rotational really only goes in one direction, so the pecking order and the technique is very different between the two. And the concentric motion allows for more flow, during the orbital motion allows for more flow during orbital atherectomy, which may theoretically decrease renal reflow and may be the reason why our pacemaker activations are fewer. In prior stents, we try to avoid using orbital atherectomy if at all possible, and rotational atherectomy still tends to be the standard choice. So this was supposed to be an innovation talk, so I spoke about orbital atherectomy, but I think you cannot not talk about other ways of managing calcium, albeit atherectomy is currently the mainstay and is currently the only FDA-approved method and mechanism of doing it. Lithoplasty, as we all know from the shockwave balloon, as you see here, it's a balloon with essentially very much similar to lithotripsy. We have shockwaves, and it actually fractures and fissures the calcium. It's essentially a generator connected to a cable connected to the catheter. As you can see here, the sizes of the catheter are listed throughout the right here, 12 millimeter length balloons. And you can see here, you one-to-one size your balloon, you inflate, you pulse the device, and as you see, the balloon inflates and the calcium fissures, and your balloon continues to inflate. And so you can see here, that's the result after 10 seconds of lithoplasty. The angiographic outcomes in their initial study, as you can see here, the mean luminal diameter pre and final, as you can see, are very significant, and the acute gain is very significant. And you can see here, overall, most importantly, the angiographic complication rate is extraordinarily low in terms of no reflow, slow flow, obstruction, and perforation. There's a Disrupt CAD2 study, which is currently in its infancy, really looking at stable, unstable angina silent ischemia, looking at moderate severe calcified lesions, and looking for lesion lengths less than 32 millimeters. And the really objective is to assess the safety and performance of this lithotripsy in a real-world registry, looking for 120 patients across 15 sites. So in conclusion, lesion-specific differences using rotational orbital atherectomy exist. However, they're currently the two mainstays of therapy for calcium. We are waiting, and we're really eagerly awaiting the ECLIPSE trial, which will hopefully give us an idea of what the differences are between plain old balloon angioplasty versus atherectomy in these very calcified lesions. Albeit, I think most of us would say that in these very calcified lesions, there's a significant crossover rate from balloon angioplasty to atherectomy. So I don't see how atherectomy is going to lose there. Concentric calcium can be difficult for orbital atherectomy, and then, as was said by the speaker earlier, really there's no reason why you cannot perform atherectomy radially. It's what we do in our clinical practice all the time, and given the fact that orbital atherectomy has taken it for larger vessels, it's the advantage that you don't have to go over a 175 burr in many cases if you're going to use rotational atherectomy, and you can do everything radially through a 6 French guide. You don't even need to upsize to a 7. And unfortunately, as we all know, we're unlikely to ever see a head-to-head randomized study for these two devices. This is probably going to be all registry data and what we see. So. Going back to those two first cases, just to say, I'm curious in the room, how many people would have used rotational atherectomy for this tortuous RCA? How many people would have used orbital atherectomy? I convinced everybody? No one's using orbital atherectomy? All right, so we used a rotational atherectomy. We did place a pacemaker given the size and the dominance of this RCA, and it was activated. As you can see here in that LAD, you can see this LAD shot. How many people would use rotational or orbital atherectomy, or would anyone use one in particular? Curious. Rotational? Anyone? Rotational? Orbital? I think this is one of those cases where you could use either, right? This is not a kind of case that you'd have to pick one versus the other, given the tortuosity and given what I said. So we ended up using orbital atherectomy in this case, and this is our final result, as you see here, of the LED lesion. Just more examples. You can see here another rotational atherectomy case, slightly more tortuous vessel, concentric calcium, very heavy, bulky calcium, especially in the proximal RCA, and that's what it looks like at the end of the rotational atherectomy run and stent placement. And that's it. Thank you very much.
That's great. It was interesting to see the responses in terms of whether people would choose orbital or rotational. And I wonder what your thinking is now. I know it's new, but how are you fitting the shockwave lithotripsy into that? There's a third choice.
There's a third choice there. So we really haven't taken on shockwave lithotripsy in large numbers as of yet. We're still in the infancy in our institution of understanding the device and getting a feel for it. So at the present time, we're still a very large rotational and orbital atherectomy shop in terms of truly debulking lesions. Where I think I would say where I think shockwave is going to be a real game changer is in those patients in whom stents are placed, where there's a lot of calcium behind those stents, where you didn't debulk up front and you didn't do what you should have done up front, and you need to now expand those stents. I think we've all done those 40 atmosphere non-compliant balloons, hoping that balloon wouldn't burst, and we tried using chocolate balloons and other balloons that are very...
That's been the role of laser, huh? We nuke it with the contrast and
Correct.
we laser it
Right.
and to deploy on the stents that cannot be expanded.
Absolutely, yeah. The spectranetics may kill us for saying this, but what's called laser bombing, right? You essentially use a laser catheter, for those of you who don't know, and you give contrast as you're running a laser and you park it. It superheats the contrast, causes a significant reaction with the contrast, and essentially explodes. In that explosion, you're attempting to fissure whatever's back there. It's very effective for fibrous plaque behind stents. It's less effective for calcified plaque, but it is something that we have been doing.
So my pacemaker use has really dropped considerably. Do you use pacemakers in most cases? We use aminophylline 5 milligrams per kilogram about 5 minutes before we start atherectomy.
Yeah, so for our rotational cases, we are doing that now. With all honesty, in that paper I presented to you earlier, that we really have seen less than a 1% activation of pacemakers with orbital in the RCA. It's probably something to do with the mechanism of how it works. It's the only explanation I have, because the same RCAs, if you roto versus you do orbital atherectomy, you definitely see a difference in terms of its heart block.
With the difference in the particle size that's created by orbital atherectomy and rotational atherectomy, do you recommend more aggressive anticoagulation or a bolus dose of 2B3A with either of them?
Not really. I mean, I think what we do typically is any atherectomy we do, you're at a risk. I don't care what device it is. You're at a risk for no reflow. We pre-treat our no reflow with whatever drug of your choice is, nicardipine, whatever you decide to use. We pre-treat. We do our atherectomy. We treat again. But we don't change our anticoagulation strategy. I don't know, I'm sure everyone in this room feels our 2B3A use for non-large thrombus burden stem use is almost zero. We very, very rarely use it.
There's one question there from the audience.
Just a quick question.
I'm sorry.
What about with guide catheter extensions? If you have guide catheter engagement issues or extensive tortuosity, you want to extend your guide catheter beyond it. Do you prefer one device versus the other if you have a guide catheter extension in place?
If you have a guide catheter extension in place, you're probably equally as likely to use a smaller burr, a smaller rotational burr, and an orbital atherectomy device. We typically we try to avoid using guide catheter extensions with atherectomy, I'll be honest with you. It's not that we've never done it, we really avoid it. Most times you don't need a whole lot of guide support for atherectomy, which is the advantage of it.
Sometimes you get in these issues where you have a distal right that's tortuous and heavily calcified, and you just don't have the push.
Right.
You just don't have the push, and that's the example I'm thinking of. I actually did one yesterday.
Okay.
I had to put a guide extension all the way to the base of the heart.
Right.
And I use CSI. I like to use CSI in that situation.
Right. You can use a 6 French. You can use a 6 French guideline or a Guidezilla through an orbital atherectomy device. It is doable. You definitely will lose all pressure ability to sense your pressure. So just be aware of that too.
In your case, do you feel like if it's that far distal, you're less likely to get the CSI stuck versus a rotoblader burr stuck?
You know, it's a thing that we debate in the lab all the time because, you know, the rotoblader, it's cutting immediately, right? Because its cutting elements are at the leading edge, whereas the CSI doesn't have a cutting element at the leading edge. So I feel like if you want to use CSI, you need to have very good support to make it work, especially if you're going distal. And I found guide catheter extensions work just fine with it.
Mm-hmm.
one more question.
Sure. I mean, it's a whole long discussion about the use of mechanical support. We do a lot of mechanical support for our high-risk complex cases, but I'll tell you the cases that are the most fruitful for using mechanical support are those atherectomy cases. Atherectomy is a complex beast that's beyond just regular. You can honestly probably get away with a left main that has a low EF. Well, without atherectomy than you will if you use atherectomy and try to not use support. You're not going to get away with that case as easily. There is something that atherectomy does to the whatever remaining reserve you have in those low EF patients that doesn't make them happy. And without having that hemodynamic support, in my opinion, we pretty much, if we have a low EF, heart failure or shock type of patient, and if you have to use atherectomy, it's a no-brainer. There's no reason to not use mechanical support in that kind of case. I think we know that from PROTECT 2, right? We know that from a lot of the literature that's been published since then, that atherectomy is a beast to itself.
Thank you.
All right, thank you.
Thank you.